Good morning, everyone. I welcome you all to this instruction course on glaucoma secondary to retinal and choroidal disorders. It's an update. It's a different type of instruction course because the topic is usually, it's not discussed. So, but it's actually very pertinent. Practically, if we see, the glaucoma specialists have to collaborate with the retinal surgeons in many of the situations. And actually, it's a teamwork which is involved. So I hope this IC will be very useful because these glaucomas are very complex and actually very challenging to treat. So I'll just give a small intro of the topics that would be presented. Can I have the introduction PPT, please? Not this. It's under my name, Subashini. There's an introduction PPT. It's not there? Okay. So the first talk would discuss the etiology and the pathogenesis, the mechanisms for the secondary glaucomas. And this will be by Dr. Venipriya, who is a postdoctoral fellow at JIPMER, Pondicherry. And followed by this, Dr. Sharmila, senior consultant at Arvind Eye Hospital, Madurai, will be discussing on the evaluation of the secondary glaucomas associated with these posterior segment disorders. Then next, Dr. Shreyas, who is assistant professor at JIPMER, he will be discussing the non-surgical management, the role of AGMs and anti-VEGFs and lasers and other such management techniques for these secondary glaucomas. Then our fourth speaker is Dr. Amit, who is associate professor at JIPMER, and he would be discussing from the vitreoretinal perspective. And the last talk would be by me on the surgical management, the role of the glaucoma surgeon in these glaucomas. So with no further ado, we'll start off with the first talk. So etiology and pathogenesis of secondary glaucomas by Dr. Venipriya.
Good morning, everyone. So today we will be seeing what are the etiology and pathogenesis of secondary glaucoma related to the retinal and choroidal disorders. So first we will define what it is. It is the group of retinal disorders associated with elevated IOP and glaucomatous disc changes and corresponding visual field loss. And the disorders can be from congenital anomalies to acquired anomalies. Sometimes even in the absence of glaucomatous disc changes and visual field loss, we can define them as glaucoma only with increased intraocular pressure, because eventually they will lead to disc changes and field loss if we didn't intervene at the proper time. So the characteristics of these glaucomas are there are multiple mechanisms involved in developing the glaucoma. So it is very important to understand the mechanism, how the glaucoma is developing, because this will help in planning the treatment strategy. Unless we treat the definite etiology and the mechanism, it is very difficult to control the intraocular pressure. And it is very difficult to diagnose because of the associated retinal and optic nerve head changes, which may complicate the evaluation of optic nerve and visual field changes. And measurement of intraocular pressure in post-vitrectomized eyes or silicone-filled eyes or gas-filled eyes will be unreliable. So we have to rely on multiple instruments. And the glaucoma is very aggressive, often needs surgical intervention, and the visual prognosis is also guarded which is an additional threat to the vision. So the etiology is classified based on congenital disorders and acquired. Congenital disorders, we have nanophthalmus, persistent hyperplastic primary vitreous, ROP, retinitis pigmentosa, and Stickler syndrome. And infection and inflammation related, AIDS and uveitis. Retinal vascular disorders, mainly neovascularization, followed by CRVO, intraocular hemorrhage, ARMD. And systemic diseases, diabetes mellitus and amyloidosis, and most importantly, tumors, either the posterior segment tumors or metastasis from other primary carcinomas, RD-associated Schwartz syndrome, POAG related associated with RD and pigmentary retraction syndrome. Ocular trauma causes glaucoma due to multiple mechanisms, elevated episcleral venous pressure, and treatment-related and intravitreal injections. We will be seeing only the important entities alone, and the mechanism can be an open-angle glaucoma, angle closure glaucoma, or combined mechanism. And sometimes the POAG is also there associated with the primary disease itself. So we have to suspect if the scenario is on bilateral side. So POAG, non-ophthalmos, RD and DM have POAG. PACG is suspected when there is a associated with CRVO and RP. So these are the various mechanisms which can lead to secondary open-angle glaucoma. The angle can be blocked by inflammatory cells, inflammatory debris, tumor cells, and in Schwartz syndrome, outer segment of the photoreceptors. Sometimes RBCs after following hyphema, or vitreous hemorrhage, hemolytic ghost cell hemosiderotic, trabeculitis or Schlemm's canalitis, anterior segment anomalies associated with ROP might be covered by fibrin membrane or neovascular membrane, elevated episcleral venous pressure, sometimes due to treatment which is steroid induced. An angle closure, it might be due to pupillary block, ciliary body effusion leading to anterior rotation of ciliary body resulting in angle closure, or mass effect due to tumor or hemorrhage, and neovascular glaucoma. See, this we should know, because for pupillary block, laser PI works, and for ciliary body and effusion, cycloplegic work. So coming to congenital disorder, we all know non-ophthalmos, there is a reduced overall dimensions are approximately 2/3 except for the crystalline lens. There is high lens eye volume ratio around 24 in non-ophthalmic eyes and only 4% in normal eyes, and it is associated with shallow AC and high hyperopia. So these are the various mechanisms. Because of the crowded AC, there can be pupillary block. Since there is an increase in the size of the lens with the age, around 4th to 6th decade, they can present with secondary angle closure glaucoma, because in the sclera, the collagen fibers are very abnormal, and they're abnormally arranged, resulting in reduced permeability of proteins, and there is impaired drainage through vortex vein, which results in choroidal effusion and anterior rotation of the ciliary body and secondary angle closure glaucoma. In ROP, the glaucoma can occur in the early phase, during the treatment phase, or in the late phase. So lifelong follow-up is needed. Even in the absence of glaucoma, there are few abnormalities seen in the anterior chamber in ROP. These are the few abnormalities: hypopigmentation of the iris root and translucent Barkhan's type membrane, prominent iris convexity, visible angle or iris vessels, pigment clumps, prominent Schwalbe line, and more than 180-degree angle closure. NVG is most importantly associated with ROP because of the retinal ischemia. Secondary angle closure glaucoma can also occur due to stage 5 ROP with RD, which pushes the lens anteriorly, and ciliary block, and uveitic glaucoma can also occur. And with PHPV, this is seen in normal birth weight. ROP is in low birth weight and it is bilateral, and PHPV is in normal birth weight and it is 90%, it is unilateral. And there are two types, anterior and posterior, and glaucoma is usually associated with the anterior type of PHPV because it is associated with microphthalmos, shallow anterior chamber, and enlarged iris vessels, and the lens is abnormal in PHPV associated with persistent fetal vessels. So the mechanism of glaucoma in PHPVs it may be due to lens-induced retrolateral membrane or bleeding from fetal vessels. Because of the absence of PZ in the lens in PHPV, the metabolism is compromised, which leads to cataract and intumescence of the lens, which can result in angle closure glaucoma. Sometimes intrareticular hemorrhage occurs from the fetal vessels into the lens. So that will also cause the change in the morphology of the lens, leading to secondary angle closure glaucoma. And the retrolental membrane contract, which leads to the anterior movement of the lens and iris, resulting in secondary angle closure glaucoma, and bleeding from fetal vessels result in vitreous hemorrhage, which can result in Gosel glaucoma, inflammation, and secondary open angle glaucoma. So these are the pictures showing the cataract with vessels and prominent ciliary process, and during surgery the bleeding in the lens. So neovascular glaucoma, the most important beast among the posterior segment disorders, causing a rise in intraocular pressure, which is a devastating and potentially blinding disease. The most common causes and important causes are CRVO, diabetic mellitus, ocular ischemic syndrome, chronic RD, and intraocular tumors. These diseases can cause widespread posterior segment ischemia. Sometimes the localized anterior segment ischemia can also cause neovascularization of the iris, which finally result in neovascular glaucoma. See, these vascular endothelial growth factors will come from the posterior segment to the anterior segment. So in the absence of lens or the vitreous, the more these agents can come into the anterior chamber. So especially after cataract surgery or after PC compromise, after vitrectomy, the NVG occurs. So these are the various stages of NVG. NVI is the first stage, and secondary open angle glaucoma, where the neovascular membrane covers the angle and causing a rise in intraocular pressure. This neovascular membrane contracts and closes the angle, resulting in secondary angle closure glaucoma. So these are the pictures showing NVI, secondary open angle glaucoma due to NVIA and angle closure type in neovascular glaucoma. The central retinal vein occlusion, NVG, is most common, especially 3 to 2. It can be from 3 days to 2 years after the vascular incident, and it occurs after 10 disc diameter of ischemia. Angle neovascularization can occur without NVI, so it is very important to do gonioscopy in follow-up, and sometimes it is associated with primary angle closure glaucoma, and because of the retinal edema and the increase in the vitreous volume, and that angle can get closed, resulting in secondary angle closure glaucoma. Glaucoma in intraocular hemorrhage, all of these can cause secondary open angle glaucoma due to the obstruction of the trabecular meshwork by the RBCs or by the lysed cells, or because of the heme damaging the trabecular meshwork. So this is the first picture is showing the RBCs obstructing the trabecular meshwork, hemolytic glaucoma, and the below pictures are showing the Gosel glaucoma, candy stripe sign. And these things are exacerbated in sickle cell hemoglobinopathy. Inflammatory disorders, it can cause glaucoma in any mechanism, open angle or angle closure glaucoma. Open angle due to trabeculitis, or due to the obstruction of the inflammatory cells, or due to the steroid response. Always have in mind, if cells are less, then it might be due to steroid induced. So it can cause pupillary block, it can cause pulling mechanism because of the inferior PAS, and pushing mechanism because of the choroidal effusion and massive exudative retinal detachment. And the intraocular tumors, primary tumors, or choroidal melanoma and retinal blastoma and choroidal hemangioma. Ocular mets, breast is most common, breast CA, and these can cause due to the mass effect or due to the melanoma cells clogging the trabecular meshwork. Glaucoma in retinoblastoma is commonly neovascular glaucoma. It is due to the compression of the retinal vessels or angiogenic factors from the tumor, or necrosis and inflammation can induce the neovascular glaucoma. So anterior segment mets are commonly associated with glaucoma compared with the posterior segment metastasis, mostly at 3 and 9 o'clock position. So both secondary open angle glaucoma and secondary angle closure glaucoma can occur because of the infiltration of the TM or due to the neovascular glaucoma. Common is CA breast and CA lung. So other retinal disorders, retinal detachment can cause if it is associated with Schwartz syndrome, where the outer segment of the photoreceptors blocks the trabecular meshwork. ARMD, sometimes that anticoagulant therapy with disciform scarring and hypertension can cause massive hemorrhagic RD or CD. And glaucoma associated with retinal treatment, like with scleral buckle, silicone oil, gases, PRP in intravitreal injections will be dealt subsequently by Dr. Amit sir. So multiple mechanisms are involved. So disappearing each mechanism is very important in taming this beat to control the intraocular pressure. Thank you.
Thank you, Dr. Venipriya. So we move on to the next talk by Dr. Sharmila on how to evaluate these secondary glaucomas following these posterior segment disorders. Over to you, Dr. Sharmila.
This is not the presentation. There's another one which is there someone to help in the audiovisual? This is for Saturday. Changed.
So as we are just sorting this out, we'll move on to the next talk, the non-surgical management role of AGMs, anti-VEGFs, and lasers by Dr. Shreyas. So over to you, Shreyas.
Good morning, one and all. I'll be discussing on medical management in glaucoma secondary to posterior segment disorders. So, as we have already seen, mechanisms in these glaucomas can be either neovascular, inflammatory, angle crowding due to pushing of lens iris diaphragm or pupillary block, or trabecular meshwork clogging. But most often it is usually mixed mechanism glaucomas which we see in this subset of patients. So how to deal with this glaucoma secondary to posterior segment disorders? We have to control three eyes. The first eye is the mainly ischemia is the main cause, culprit. Treat the cause of ischemia. The second eye is control of intraocular pressure, and the third eye is controlling inflammation. So coming on to management of the first eye, ischemia management. So we have to recognize the ischemia in certain disorders. So in PDR and ocular ischemic syndromes, which are some of the common causes of neovascular glaucoma, the time of onset of NVG is unpredictable. But in CRVO, in the pre-anti-VEGF era, they used to say that it's a 100-day glaucoma and the maximum risk is seen in first 7 months. In anti-VEGF era, it is no more 100-day glaucoma. The anti-VEGF therapy may reset the clock of NVG onset, extending the risk beyond 7 months. So two things which increase the risk of NVG are poor vision and presence of RAPD, which favor more towards an ischemic CRVO, and hence an undilated pupil examination is mandatory at every visit to pick up early NVIs. So coming on to ischemia management per se, we have three treatment options. The retinal laser photocoagulation, which is the mainstay of treatment, anti-VEGFs, which are used as a temporary adjunctive therapy, and retinal cryotherapy, less often used these days for recurrent NVIs. So coming on to retinal laser photocoagulation, it is a treatment of choice wherever retinal ischemia is the cause of NVG. It reduces the VEGF load. It is indicated in all stages of NVG. It prevents further angle new vessel formation and it prevents goniosynic formation. It also cuts off the angiogenic stimuli and enhances the success of trabeculectomy. Hence, it is preferably better to do PRP before trabeculectomy at least 1 week prior. So preferably we have to wait for 3 to 4 weeks before planning trabeculectomy. So what about role of prophylactic laser in CRVO to prevent NVG? So CVO's study said that the prophylactic PRP does not totally prevent NVI or NVA, and prompt regression of NVI or NVA happens when PRP is given after the onset of NVI or NVA. So Harry et al. Have also said that the risk of NVG is seen only in a very small proportion of CRVO patients, and prophylactic PRP destroys peripheral fields in already compromised central vision due to macular edema and macular ischemia. Hence, there is no role of prophylactic laser in CRVO to prevent NVG, and only once we see NVI or NVA, we have to do PRP. So coming on to treatment protocol for PRP in NVG, special things which we should see in when we are treating NVG when we are doing PRP in patients with NVG is that we have to do like little tight PRP. So usually when we do conventional PRP, the spacing is about 1 spot size, whereas in NVG, ideally it should be very tight, half spot spacing is advocated. So number of sittings is 2 to 3, and number of final burns is 1500 to 2000, which is approximately 500 more than the conventional PRP. So red laser can be used in the presence of hazy media. So in conventional PRP, it is up to the equator, but in NVG, to whatever extent we can see the retina, we can do the laser. Sometimes we can also use indentation and do laser using laser indirect ophthalmoscopy. So coming on to endo laser, it is used preoperatively during PPV. It is useful for cases with media haze like vitreous hemorrhage. So one more gonio-photocoagulation. Here direct laser treatment is done to prevent development of NVG. It was suggested as an adjunct to PRP in the pre-anti-VEGF era. It is largely replaced by anti-VEGF therapy these days. So coming to adjunctive therapy, anti-VEGFs, they have two important roles, anti-angiogenic and anti-fibrotic properties. Bevacizumab is most commonly used. Others include ranibizumab and aflibercept. Regression of NVI and NVA occurs in 1 to 7 days after the injection. They are used as adjunct to achieve rapid regression of NVI. And however, PRP remains a definitive treatment. So they can be delivered both by intravitreal or intracameral. Intracameral is easier to perform for most of the anterior segment surgeons. It leads to rapid regression of NVA and better IOP control. For patient planned for trabeculectomy, intracameral may be preferred. Dose is bevacizumab 1.25 mg, ranibizumab is 0.5 mg per 0.05 ml. So this is a case where you can see on the right image, you can see that there are profuse NVIs. After 2 days of ranibizumab injection, there is complete regression of these NVIs. So coming on to preoperative anti-VEGF before trabeculectomy, giving anti-VEGF before TRAB reduces the risk of postoperative complications like hyphema. It also increases success and helps to achieve better short-term IOP control. So coming on to third important thing in management of ischemia, the anti-retinal cryopexy. It is done less frequently these days. Current applications include during PPV when we need to ablate the anti-retina, which is inaccessible to laser, and for recurrent NVIs after adequate PRP. So the procedure is that we follow the rule of 8. 8 spots per quadrant for 8 seconds and approximately 8 millimeter from the limbus. That is, we put 2 rows anterior to the equator. So the next step in management, dealing with the second eye, IOP management. IOP management in the secondary glaucomas, aqueous suppressants are the drugs of choice. Oral and topical carbonic anhydrase inhibitors, topical beta blockers, and alpha-2 agonists can be used. Prostaglandin analogs are not that preferred because they may aggravate inflammation, and also the neovascular membrane may prevent the aqueous access to the uvascular outflow pathway. It is used only when IOP is not controlled by other medications. Osmotic agents are used intermittently to control extreme high IOPs and to clear cornea to facilitate PRP. Myotics are better avoided because they may increase inflammation and worsen synovial angle closure. Coming on to laser cyclophotocoagulation, the end-stage procedures for management of glaucoma. The mechanism of action is that it has 2 roles. One is permanent by direct thermal destruction of ciliary epithelium, seen 4 weeks after cyclophotocoagulation. Transient effect is seen immediately by inducing inflammation and decreases in aqueous production and increase in uvascular outflow. Laser cyclophotocoagulation are of 2 types, transcleral and endoscopic. Transcleral is again of 2 types, conventional and subliminal. First, we'll see about conventional DLCP. Here, a diode laser is used. It is done using either a G probe. If you don't have a G probe, we can use this sclerotic scatter. We can use a vitrectomy endoilluminator, which is used at limbus to generate a sclerotic scatter. And marking is done at the junction of the lighter and the darker area. And the laser is given at this junction. So coming on to conventional DLCP settings, the power is started usually at 1750 to 2000 milliwatts for 2 seconds. We have to increase by 250 milliwatts till an audible pop sound is heard, then turn down the energy by 250 milliwatts and then proceed with the treatment. Usually 6 applications are done per quadrant. We do up to 180 to 270 degree. We have to avoid 3 and 9 o'clock positions. So coming on to complications of conventional DLCP, it is associated with high chances of inflammation, hypotony, pain, conjunctival scarring, CME, and vision loss. So we currently follow this subliminal cyclophotocoagulation, which is relatively much more safer. It uses series of brief microsecond pulses with on and off duty cycle. The on time generates the heat sufficient to coagulate the target tissues, and the off time allows cooling, and the heat does not reach the adjacent structures, hence reduces collateral damage. It is associated with reduced complications and can reduce IOP by almost 30% in various types of glaucomas. So the parameter, again, it uses diode laser. The power is around 2000 milliwatts. Duty cycle is 31.3%. Treatment duration is 160 seconds, 80 seconds in the upper part and 80 seconds in the inferior part of the sclera. Here the tip of the probe is positioned 3 mm posterior to the limbus. The probe should be held perpendicular to the eyeball. The tip is then continuously moved in sweeping motions to deliver the laser treatment from 9:30 to 2:30 clock superiorly and 3:30 to 8:30 clock inferiorly. So last one, the cyclocryotherapy. Here sub-zero temperatures of cryotherapy is applied to freeze the ciliary body tissues, leading to destruction of ciliary epithelium and hence decreased aqueous production. It is usually indicated these days for painful blind eyes, and it has been largely replaced by laser cyclophotocoagulation. The extent of treatment is usually 180 degree, 5 to 8 applications are given. In seeing eyes, it is usually avoided. 360 degree is never done due to high chances of complications. The procedure, we use a cryotip of around 3 millimeters, which forms an ice ball of 5 millimeter. It is performed under local block only. Placement around 2 millimeter from the limbus. The cryoprobe is firmly placed on the sclera and freezed for 60 seconds. And slow thawing is allowed. Post-procedure, we have to give topical steroids and cycloplegics and systemic NSAIDs for pain management. Anti-glaucoma medications are continued till the IOP reduction is achieved. Coming on to the third eye management, that is inflammation control. So inflammation control, steroids remain the mainstay of treatment in inflammatory glaucomas. Topical steroids reduce congestion and inflammation and also help to regress NVIs and NVA in patients with NVG. Systemic steroids are reserved for non-infectious intermediate and posterior uveitis, can also be used for glaucomas associated with choroidal effusion. So last but not least, cycloplegics. The role is that they reduce uveal congestion, they break synechial and occlusive pupillae, it pushes the lens iris diaphragm posteriorly, and it is used as adjunct treatment in inflammatory glaucomas, neovascular glaucomas, malignant glaucomas, and in choroidal effusions. Thank you.
Thank you, Dr. Shreyas. So we go to the second talk, Evaluation of Secondary Glaucomas by Dr. Sharmila.
Thank you very much, Subashini, and I thank a few of you who have found the way to this auditorium. I know it was a complex way. Anyways, this is going to be the 12 minutes I'm going to be talking about evaluation of glaucomas associated with posterior segment disorders. So we heard Veni telling about a lot of causes that might lead to glaucoma secondary to a posterior segment disorder. So let me just take you to the journey of how to unravel this mystery. So number one tip which I would like to give is, whenever a patient walks into your room, you have to start from there. So first, look at the patient, listen to the patient, and then speak to the patient. Most of the information you can get with just looking, listening, and speaking. So number one, when you look at the patient, when the presentation is unilateral, you have a number of conditions that present unilaterally, like the neovascular glaucoma, the uveitic glaucoma, any history of trauma, pupillary block, etc. And those which happen bilaterally, secondary to an ocular ischemic syndrome, nanophthalmic eyes, or any steroid response. So looking at this, you get some information. Next, you have to listen to how they present it. So ask, what is the first presenting symptom? Was it a decreased vision? Was it a pain? Was it raised IOP, which is a sign that you're going to elicit? Look at the anterior chamber depth. Look for any shallow or deeper anterior chamber, because a lot of this will give you an information as to what is the type of glaucoma that you're dealing with and how you're going to treat it. So sometimes the patients may be presenting to your clinic as the first presentation before you diagnose a posterior segment pathology. And then speak. ask a lot of history, probe into the patient's history, look, ask and speak. So basically you look at the condition, ask for systemic illness. What is the systemic condition? Whether they are having diabetes mellitus, how often they've been on treatment, how long they've been on treatment, look for ask for history of hypertension, any history of any infective disorders, and also ask for any history of any treatment for any malignancy. So a lot of information you can get by just getting the history. Next important thing is medication history. You'll also have to look at all of the medicines that the patient is taking. Sometimes they may be having a skin disorder where they may be using steroids or maybe a rheumatoid arthritis. So look at the history and then take very careful history regarding the oral steroid, use of any intravitreal injections previously. So all of this has to be noted very clearly. And then most important thing is surgical history. We all know that most of our retinal surgeons, they often keep sending patients to us. Most of these reason is because of the glaucomas that are associated following a vitreoretinal procedure. So any known posterior segment disease with a history of vitreoretinal surgery, like it could be just an injection, it could be a panretinal photocoagulation, it could be a scleral buccal surgery, it could be a gas or an oil which is inside the eye, and that might be causing a secondary glaucoma. So basic evaluation. The other thing is a basic evaluation. So look at a complete comprehensive evaluation. So aim at that. Number one is best corrected visual acuity. Most often you get a good clue as to what is the diagnosis based on the visual acuity itself. So there may be patients who were very good 6/6 earlier and they just come with sudden loss of vision. So sudden loss of vision could be a vitreous hemorrhage, could be an ischemic optic neuropathy. So you have to understand that these are the two things that can be commonly presenting with poor vision. And very carefully examine the anterior segment. And most importantly, look at the iris for a lot of details. Look for presence of neovascularization. Pupillary reactions, very, very important. See the pupil reaction, whether it is brisk, whether there is a relative afferent pupillary defect, whether it is fixed. And all of this will give you a clue as to what is the condition that you're dealing with. And one other thing which goes without saying is careful examination of the anterior chamber. I think 50% of the diagnosis you can clinch with this. So look at the anterior chamber, see whether it is a normal depth or it's a shallow chamber. Because normal depth, it can happen in many other conditions like posterior segment disorders which have undergone surgeries, like presence of silicone oil, any hyphema, trauma, ghost cells in the anterior chamber, presence of cells or pigments. And shallow chambers is because of any pupillary block. That could be because of a silicone oil, any nanophthalmic eye, or chronic NVG or uveitic condition. And also examine the anterior chamber for contents. So look for the presence of cells, look for the presence of blood, look for presence of silicone oil, how they present. It's usually an inverse hypopyon that you see, like what is seen here. Sometimes they may be like retained lens fragments and other things. And now going on to the examination. No examination is complete without you doing a gonioscopy or an intraocular pressure assessment. So intraocular pressure assessment, again, whether it is low or high, that might give you a clue as to what is the diagnosis. And very, very important investigation, which is indispensable, is a gonioscopic evaluation in these eyes, because we are dealing with posterior segment disorders where you see a lot of neovascularization that can be seen, particularly in the angles. And carefully examine the fundus. And additionally, we might have to also look for other investigations. We might have to rely on B-scan and UBM because many times we might not be able to see the posterior segment because of poor visibility, because of vitreous hemorrhage or any blood that is present. So such conditions you have to rely on B-scan, and sometimes you might also have to look at the UBM to find out the pupillary block, presence of any cyclodialysis or any hidden malignancy in the ciliary body. So neovascular glaucoma, we all know. So I'm going to be just talking about few common conditions and how you evaluate it. So neovascular glaucoma, we all know it's a very, very common presentation which developed glaucoma, and this is basically because of an ischemia. So whenever there is ischemia, we have to keep very important look for neovascularization in the angle, in the iris, and also look for the relative afferent pupillary defect. So presentation of the fundus will give you a clue as to what is the type of neovascular glaucoma that is happening, whether it is because of a diabetic retinopathy, whether it is because of a vein occlusion or an ocular ischemic syndrome. So previous speaker has also told a lot about the neovascularization. Only thing I would like to emphasize here is look at neovascularization at a very high magnification, because very often there will be very fine small vessels which will be missed with just a simple one-time examination. You have to put it at a higher magnification to carefully look at the neovascularization. Also look at the angle for the presence of anterior synechiae or a neovascularization which is present in the angle. So other investigations which have to be definitely done when you see a neovascularization is look for the blood sugar, lipid profile, HbA1c, serum homocysteine, protein C or S deficiencies, fundus fluorescein angiography, retinal OCT to rule out any associated macular edema, B scan if you're not able to see the fundus, which is hemorrhage, will be picked up by B scan, carotid Doppler. Yes, it's very, very important to see the blood flow of the carotid arteries, and so this will give you a clue as to what you're dealing with. Now we move on to the other common entity, which my previous speaker also said, like glaucomas that follow a vitreoretinal procedure. So we often get referrals from the retina clinic following a vitreoretinal procedure. It could be because of a tight buccal, it could be because of retained silicone oil which is not removed, it could be because of gas, intravitreal injections, and even after a PRP. So this is accounting for around 1 to 4% of glaucomas that we see. So intraocular pressure definitely is very high in all of these patients, and many of them even present as an angle closure. So what here we have to look at is look at the eye. Sometimes we might have to see how the buccal is, whether it is a tight encircling band, high scleral buccal. All of this might be a risk factor for an angle closure glaucoma. Look at the presence of silicone oil. So it can present either as an open angle or it could present as a pupillary blocker. So carefully examine this to understand what will be the nature of treatment that you're going to be targeting. And now we move on to the uveitic glaucomas. So we all know uveitis also is a very common entity, and you have to again look at certain features which might be very, very clear cut for uveitis, and they may present as secondary open angle glaucoma, angle closure, or even present with a pupillary block. So key is examine the anterior chamber carefully and also do a gonioscopy to understand what is the nature of the angle closure that you're dealing with. And importantly, you can also pick up other associated signs with uveitis when you carefully examine the slit lamp. Look for KPs, look for cells and flare, look for nodules, posterior synechiae, complicated cataract, and PAS. And in uveitis, not always you will have high intraocular pressure. You may also have patients who present with low intraocular pressure because of ciliary shutdown. So carefully look at the intraocular pressure also and do not rule out the possibility of underlying uveitis. And of course, other associated fundus findings along with uveitis. And when you know it is something you're dealing with uveitis, you have to do a complete workout for a uveitic profile. So basically, you do all the investigations that will clinch the diagnosis as to the cause of uveitis, like HLA-B27, VDRL, TB profile, sarcoidosis, and even sometimes we might have to do an aqueous humor tap to look at the microscopy and culture. Now we move on to the other common entity, which is glaucomas that occur secondary to a ocular trauma. We do see patients who present like this with hyphema, with prolapse of iris. And so you have to understand what is the nature of trauma. So probe into the history, understand the nature of trauma, and always document the visual acuity, because most of these patients are medico-legal cases. So you have to document the vision. And also look at the pupils for RAPD. And looking at the pupil itself will give you a clue as to whether it is a trauma. Sometimes patients deny a history of trauma. But looking at the pupil, asymmetry between the pupil, any presence of sphincter tear or traumatic mydriasis, all of this will give you a clue as to the traumatic glaucoma. And you have various types of presentation which happen with any case of trauma, and that will also give you a clue as to how to manage these patients. So again, trauma also, you can see patients presenting with low intraocular pressure or high intraocular pressure. One single indispensable tool for clinching a diagnosis is gonioscopy. You look at the gonioscopy, you find out there is an angle recession. Sometimes you even often see a cyclodialysis cleft or even a hidden foreign body inside the eye. Other investigations which are very important in a case of trauma is B scan, UBM, and also a presence of any foreign body which is picked up by X-ray CT, and look for any associated damage. Now, nanophthalmos, as previously Vini had mentioned, she has mentioned quite a lot about nanophthalmos. So basically, I just want to emphasize that they present bilaterally, and they have typical features of a very, very short eye. And carefully look at all the features for that eye, and then do a gonioscopy. You get a clue that it is an angle closure and it is bilateral. Fundus, of course, has typical features of hyperopic disc, ILM folds, foveal hypoplasia, etc. And one important tool is IOL master, because it gives all of the information as to how to diagnose a nanophthalmic eye. You get axial length, you get lens thickness, you get the CCT, you get the RCS by the B scan, and sometimes you might have to do an ASOCT to decide on the laser PI. There may be other conditions that can cause glaucoma, like glaucoma secondary to an ocular tumor. It could be an open angle or a closed angle. Again, depending upon the intraocular pressure and neovascularization, which may happen very late, and even in gonioscopy, you might have to deal the management. And again, for this, to clinch the diagnosis, you have to do a B scan, you have to do a UBM to pick up any unknown mass that is present behind the ciliary body. And sometimes we might have to take a FNAC and do some chest X-ray, CT, and PET scan to look for mets. So I would like to conclude by saying that glaucomas secondary to posterior segment disorders are complex entities. They warrant a detailed history and clinical evaluation to clinch the appropriate diagnosis and timely management. Most often, it could be the first presentation of a hidden posterior segment pathology. Treatment should be individualized based on the angle status, optic nerve head, and disease severity. It needs multidisciplinary approach in solving this puzzle. So it is a team effort involving multiple departments. Thank you for patient hearing.
Thank you, Dr. Sharmila. So she has emphasized on how a systematic evaluation helps in not missing the diagnosis. So over to Dr. Amit, who would be talking on the disorders associated with vitreoretinal surgeries, the glaucomas resulting from vitreoretinal surgeries. Over to you.
A very good morning to all. At the outset, I would like to thank AIOC Scientific Committee for giving us the opportunity to present this IC, and I would also like to thank Subashini ma'am for making me a part of this IC. So I'll be talking over the next 10 minutes about the retinal surgeries which lead to secondary glaucoma. So commonly performed retinal procedures for various retinal diseases are scleral buckling, pars plana vitrectomy, PPV with combined encircling band, or it can be intravitreal injection of gas salon, or at the end of vitrectomy we can inject gas or inject silicone oil inside the eye. So all these surgeries can lead to short-term elevations of IOP in the immediate post-op period, and also ultimately they can lead to long-term glaucomatous damage if not treated early. So glaucoma in these cases are usually refractory to the conventional therapies. So this one study, which is published in 2008, they found that post-vitrectomy glaucoma, almost 14% of all cases of secondary glaucoma were post-vitrectomy glaucoma. So presence of glaucoma in these eyes usually doesn't affect the retinal reattachment, but it will ultimately affect the final visual outcome. So the predisposing factors for glaucoma in these eyes after vitrectomy can be a pre-existing glaucoma, eyes with trauma, myopic eyes, and some of the surgery related is if there is an scleral buckle done, or lensectomy has been done, or following intravitreal gas or silicone oil injection. So what happens in eyes who had already pre-existing glaucoma, in those eyes if PPV is done, IOP is often difficult to control because the surgery related inflammation and debris decrease the aqueous outflow in the immediate post-op period, and also the optic disc and the retina nerve fiber layer in vitrectomized eyes are most susceptible to damage after the procedure. PPV also alters the intraocular biochemical environment with tendency to reduce the aqueous outflow. So these glaucoma following PPV are one of the most refractory cases of glaucoma. There is associated conjunctival scarring and chronic inflammation following multiple wear surgeries. This leads to difficulty of the traditional filtering surgery, which is often unsuccessful. And also multiple wear procedures can exhaust the RNFL reserves due to transient IOP elevation either during the surgery or sustained IOP elevation in the immediate post-op period. So despite adequate IOP control, glaucoma progression can be observed even during the long-term follow-up in these cases, and control of secondary glaucoma in these eyes after wear surgery may need a larger IOP reduction compared to a normal glaucoma case to prevent evolution of the RNFL loss. So following PPV, glaucoma can be an open-angle glaucoma. It can be because of a pre-existing glaucoma, expansion of the gases, silicone oil overfill. It can be blood-mediated because of associated inflammation, that is trabeculitis, or it can be because of steroid response or mechanical obstruction to the aqueous outflow by the silicone oil, which is emulsified or non-emulsified by fibrin or retained viscoelastic agents. It can be also angle closure glaucoma. Again, it can be a pre-existing angle closure case where you have done a vitrectomy, or it can be because of pupillary block, because of gas, silicone oil, fibrin, or the IOL. It can be a ciliary body edema, which is usually seen following excessive cryo laser, or also during after scleral buccal. We can see that inflammation again can cause annular choroidal detachment and cause angle closure glaucoma. There can be anterior rotation of the ciliary body because of more anteriorly placed scleral buccal. There can be compromised vortex vein drainage because of a tight scleral buccal, and in cases of NVG there can be cases of NVG in PDR CRVO cases, or sometimes in chronic peripheral chronic RD following PPV in the periphery. The RD is persistent, that can cause anterior PVR and neovascular glaucoma. So coming to silicone oil induced glaucoma, it's the second most complication of following PPV with silicone oil tamponade after cataract. Prevalence has been seen to be ranging from 2 to almost 56% in various studies, and almost one study which was conducted in 2005, out of all post-vitrectomy patients with glaucoma, silicone oil was found to be the offending agent in almost 73% cases, and most of these cases had the endotamponate for more than 3 months duration. And this silicone oil-induced glaucoma can be early onset or a late onset glaucoma. Early onset glaucoma can be again angle closure because of pupillary block by the migration of silicone oil from the posterior chamber to the anterior chamber. There can be pre-existing synechiae, or immediately after surgery because of inflammation synechiae can form, or it can be an open angle glaucoma because of, in a case of pre-existing open angle glaucoma or inflammation causing trabeculitis, or it can be mechanical blockage of the trabecular meshock by the silicone oil present in the anterior chamber, or also because of a steroid response. So here you can see in this picture that the silicone oil can, if it is overfilled eye, can push the iris lens diaphragm anteriorly and cause an angle closure glaucoma. So some cases like FAK or pseudo-FAK, when you are doing a vitrectomy, it's always advisable to do a inferior iridectomy, which is also known as endos iridectomy, which allows the silicone oil to fall back into the posterior chamber and can establish a normal aqueous outflow and can reduce the angle closure attack. So when there is a large silicone oil bubble in the immediate post-op period in the anterior chamber, so what can be done? If we can be removed through viscoelastics, but again this viscoelastic technique can cause emulsification of the silicone oil subsequently, and also migration of other silicone oil into the anterior chamber. So what is the best technique is using an AC maintainer with a high infusion rate, and then using another extractor port through the another side port and extracting the silicone oil from the anterior chamber. At the same time, the anterior chamber will be filled up by the air through the infusion cannula, and the anterior chamber will be maintained. There will be no collapse of the anterior chamber during this period, and there will be no migration of silicone oil from the posterior chamber into the anterior chamber. So coming to late onset glaucoma, again the risk of consistently raised IOP is almost 5 times higher than when silicone oil is used compared to when BSS or any gas is used at the end of the surgery. Risk factors are again FAK cases, presence of silicone oil in the anterior chamber at the end of the surgery, emulsification of silicone oil, rubeosis iridis, and presence of peripheral anterior synechiae. The mechanisms of late angle closure glaucoma can be angle closure through PAS or neovascular membranes, or inflammation, or also because of emulsified silicone oil droplets, and additionally there can be direct neurotoxic effect on the optic nerve fibers by silicone oil. So which are the eyes which are at risk of emulsification of silicone oil after the silicone oil is injected? These aphakic eyes, again the eyes with trauma. If there is an underfill of silicone oil, because there will be movement of the silicone oil and it will be mixing with the aqueous more, and then those eyes also at risk of earlier emulsification of the silicone oil. So management of late onset silicone oil induced glaucoma, either silicone oil extraction can be done alone, and success rate is around 45 to 60%. And some studies have the combined silicone oil extraction with glaucoma surgery in the same sitting, but those cases hypotony has been found to be a major cause of failure in these cases. So always it is better to do the silicone oil extraction first, give topical medications. If not controlled, then do a glaucoma surgery if needed. So what are the glaucoma surgeries? Trabeculectomy, as I discussed before, most of the time is more prone for failure because there is less available naive conjunctiva, and presence of emulsified silicone oil can induce inflammation and fibrosis at the level of the trabecular meshock as well as in the subconjunctival space. So best option will be the glaucoma drainage devices. So there are various studies on MF glaucoma bulb in silicone induced glaucoma, where the success rate has been found to be as high as 60 to 80%. So again, there might be some problem with silicon GDD placement in these eyes. So the quadrant which is usually preferred is the infranasal quadrant, and post-operative failure of GDD is again because of migration of silicon oil into the subconjunctival space through the tube. So other options in these cases can be diode laser, as Dr. Sheash has already mentioned, and then in NVG, which we use, here also it can be used. Then express mini shunt has been used in some early cases, and also GAT has been tried out in various studies. The advantage with this GAT is it can spare the conjunctiva for future GDD or a BLEP procedure. So coming to glaucoma after scleral buccal, incidence is around 1.4 to 4.4%. It is mainly because of impaired venous drainage through the vortex veins. Because of the surgery-related inflammation, there will be congestion and swelling of the ciliary body, and that causes anterior rotation, pushing the lens iris diaphragm forward. Risk factors are again the pre-existing angle closure cases, use of an encircling band, if the band is placed too anteriorly, and if there is post-operative choroidal detachment. So most of these cases do well with the topical medications in the immediate post-op period. Once the inflammation subsides, it can reverse back. So topical corticosteroids, cycloplegics can be given, as Dr. Sheash had mentioned, in inflammatory cases. ACOS suppressant should be given. Myotic should be, however, avoided in these cases. So laser therapy, actually laser iridotomy doesn't help in these cases. Laser iridoplasty can be tried. In cases where all these initial measures fail, we have to go for glaucoma drainage procedures. So this certain modification can be done. If already there is a scleral buccal, you can just place the tube below the buccal, which acts as the fibrous capsule around the buccal will act as a reservoir for the aqueous collection. Also some modified techniques of trimming the wings of the verbal bulb can be tried in cases of buccal-induced glaucoma. So again, failure of this GDD occurs because of obstruction of the distal tube by fibrous tissue. The last thing is glaucoma after intravitreal gas injection. So pneumatic retinopexy, the gases used commonly are SF6 and C3F8. They provide a prolonged tamponade as compared to AR, which is injected in some cases at the end of vitrectomy. So what you should remember here is the doubling time of these gases. These gases are often expansile gases, and SF6 volume, whatever you are injecting, usually doubles by around 48 hours, and C3F8 doubles by up to 4 times in size, increases by around 72 hours. So this is the time when most of these patients present with increased risk of glaucoma. So risk of IOP elevation after SF6 injection has been found to be as the range from 6 to as high as 67%, and most often seen with when 100% SF6 gas is injected. With C3F8 also the percentage is around 18 to 60%. This mechanism is because the injection of expansile gases into the vitreous cavity can cause anterior displacement of the lens iris diaphragm immediately in the post-op period, which can cause secondary angle closure with or without pupillary glaucoma. And greatest pressure elevation, as I mentioned, is during the period of maximum gas expansion, and the rate of liquid vitreous and aqueous egress cannot keep pace with the increasing gas volume. So that's why these patients present with very high IOP. So how can you prevent? We can use 20% SF6 and 14% C3F8, and also the volume we should not inject more volume. So for pneumatic retinopexy in a non-vitrectomized eye, maximum volume we inject is 0.3 ml. In a vitrectomized eye, 20% up to 4 ml we should inject, and should advise the patients to maintain a face down position. And also high altitude can cause expansion of the bubble. So these patients should be advised not to travel to higher altitude at least 2 weeks after the surgery. So these patients, medical therapy can be tried, laser can be given. So to summarize, PPV in such cases is glaucoma in cases eyes with PPV is a challenge for the ophthalmologist. So based on the mechanism, we have various options to treat. Either do a laser, or if there is a overfill, we can remove the silicone oil immediate post-op, or do silicone oil removal and then observe, and then do a trabeculectomy or GDD if needed in the follow-up time. Thank you.
Thank you, Dr. Ahmed. Now I call upon Dr. Subashini to deliver a talk on surgical management, the role of glaucoma surgeon.
Hello again. So far we had seen the previous speakers have spoken on the causes, the mechanisms for these secondary glaucomas, as well as then how to evaluate systematically, and then the non-surgical management. So I would be talking about the surgical management. So, which are the glaucomas which require surgical intervention? So, as far as I can see, so it's only a small proportion of the glaucomas. Mainly, it's the neovascular glaucoma, then some of the glaucomas following vitreoretinal surgery, and I'll also touch upon the choroidal detachment, which occurs as a complication following any glaucoma surgery for these conditions. So moving on to neovascular glaucoma. So majority, especially in the open angle stage, it's managed medically. So the management actually not only consists of only reduction in the IOPs by medications and by surgery, we also have to inhibit the neovascular drive. So, and that is done by panretinal photocoagulation and anti-VEGFs. So the indications for the surgical treatment of neovascular glaucoma are when there is valuable visual acuity and insufficient pharmacological control of the IOP, and when there's a closed antechamber angle due to synechiae. And literature has shown that more than 50% of the eyes with neovascular glaucoma require surgical IOP control. The options we have in hand are, one is the trabeculectomy with MMC, then the glaucoma drainage device, and the CPC. So, talking about trabeculectomy with MMC, so the success rate is much less compared to a TRAB in other glaucomas which is done. So, it ranges between 62 to 80% in some studies at 1 year, and it further decreases over the years. So it's very important that preoperative intravitreal bevacizumab injection be given before a trabeculectomy, but because it has shown to improve the surgical outcomes and reduce the postoperative risk of hyphema. And there's a study which has shown that primary TRAB combined with intravitreal injection of bevacizumab and subconjunctival MMC, it resulted in decreased IOP compared to just use of subconjunctival MMC without intravitreal injection. So it's become standard practice that intravitreal injections are given 1 or 2 weeks before planning the trabeculectomy surgery. So this is a quick surgical video of how a trabeculectomy is done. So in TRAB in neovascular glaucoma, it's better to avoid the superior rectus brittle suture, better to take a corneal suture, but because it can induce some hematoma and cause more inflammation and failure. So I had injected mitomycin 20 microgram, and then now raised a phonics-based conjunctival flap. The cautery is done. So the rest of the steps are just like for a regular TRAB. A triangular groove is made, and the flap is raised. A partial thickness scleral flap is raised. So after entering the chamber, then with a Kelly punch, you can punch out 2 or 3 punches of the corneal scleral tissue. After the PI, the chamber is formed and checked for the flow through the scleral flap, and then we suture the flap. The conjunctiva is sutured snugly. And you can depress near the scleral flap and check whether the bleb is forming. So this is the post-op picture, and you can see there is no hyphema, and the bleb is well formed, and the pressure also was under control. So moving on to glaucoma drainage devices, this is preferred if the trabeculectomy fails or when there's a high risk of failure. So many people straight away go for GDDs in neovascular glaucoma because there's a high incidence of conjunctival scarring and inflammation in these cases. So now the question is whether to choose whether a valved implant or a non-valved implant. And any, be it a valved or a non-valved, here again, just like for a trap, it's good to use preoperative adjuvant bevacizumab or any other anti-VEGFs, and this actually improves the surgical outcome. Though there are some studies which show contradictory reports that it doesn't have a role. Choosing between Ahmed and Burwell, there's a study, and this has shown that Burwell has an upper edge, and the pressure control is much better with Burwell than with Ahmed. The failure rate is also less. This is a video of glaucoma drainage device. Here I have used the RD implant. You can see the conjunctiva being scarred because of the pars plana vitrectomy that was done in this case. First, the muscle, the superior rectus and the lateral rectus are identified, as we usually plan to place the GDD in the supratemporal quadrant. After the priming, the ripcord suture is placed. This is a 3-0 supramed suture. Then the vicryl tie, 1 or 2 sutures are placed with 6-0 vicryl. Then the plate is placed such that the wings of the plate are under the muscles. Nothing different from the usual kind of surgeries. Okay. Moving on to the glaucomas following vitreoretinal surgery. And I mean, here it depends on what type of surgery. So if it's a scleral buckle, so what can be done? We saw the mechanisms which was elaborately told by Dr. Amit. So when there's a scleral buckle, so in the early stages, you can just think of just loosening the encirclage band. That itself would help to control the pressures. So the other, if it is an old case of scleral buckle, then some say you can even insert the tube into the capsule of the pre-existing encircling band. So the capsule which is formed by the encircling band, into that you can insert just the tube. The other way is like placing a GDD, and then you can trim the plate because of the lack of space, because of the band occupying that area. So you can trim the plate. Or in most cases, it's much easy. So you can just place a plate over the band and do as a regular surgery. In case of pars plana vitrectomy, glaucoma following pars plana vitrectomy, we can consider placing a pars plana tube if the cornea is compromised or if it's a post-PKI, or you can even use an antechamber tube if the chamber is well formed and there are no peripheral anterior-synechiae. For glaucomas, because of silicone oil removal itself is not enough. That's what studies have shown. So you might have to combine with the glaucoma surgery. So trabs have been tried, but with poor success rate, and so has been with express shunt and GAT. So there are some studies which have been done on these glaucomas, but the efficiency is much less. So the best option would be to go for a glaucoma drainage tube with an inferior, placing the tube inferiorly, because if you place the tube superiorly, the silicone oil can just enter the tube and then escape through the tube to the subconjunctival area over the bleb that is formed over the plate, and this can induce a lot of inflammation and fibrosis, and the GDD also can fail. With respect to glaucomas following use of these intravitreal gases, here again you can place a GDD, and either in the pars plana scleral fistula, or you can place an antechamber tube. So talking about choroidal detachment following the surgeries for these secondary glaucomas, a serous choroidal detachment can occur following a bleb leak or overfiltration, following a trabeculectomy. And here you can see the chamber is very shallow because of overfiltration, and you can see the kissing choroidals on fundus examination. And it's not necessary that for serous choroidal detachment that you have to immediately drain the choroidal fluid. So we can temporarily manage conservatively. So you can use atropine eye ointment and help to push the iris lens diaphragm backwards and allow for the fluid to absorb. So you can even give oral steroids to help in faster absorption of the fluid. The risk factors for a serous choroidal detachment are hypertension, older age, prior vitrectomy, nanophthalmus, and elevated episcleral venous pressure as seen in Sturge-Weber's and other conditions. So management conservative, as I said, topical steroids, atropine, and oral steroids. Intervention can be just a mild intervention by just forming the antechamber. That itself would be enough. But choroidal drainage would be considered in these conditions. So when there's a flat antechamber with lens corneal touch in the center, kissing choroidals, and the hypotony is there for a long duration. So this is how a choroidal drainage is done by the glaucoma surgeon. A radial incision is made around 2.5 to 3 mm from the limbus. You have to magnify the area, then hold the lips of the incision using 0.12, that's the limbs forceps, and then gently deepen the incision till you reach the suprachoroidal space, then pass a cyclodialysis spatula into the suprachoroidal space and to break any loculets, pockets of fluid which are there. You can see that straw-colored fluid coming out. So you need not, you don't have to suture the scleral inside sclera. So just the conjunctival suturing would do. The other way is by here again a radial incision is made. A better method is by placing a anterior chamber maintainer. So this will help prevent collapse of the anterior chamber. So that's what. So this is in short, in a nutshell, how you manage surgically these glaucomas. So thank you.
Thank you, Subashini. We have some time for questions. We have around 10 minutes.
Any questions from the floor? We have some 10 minutes left, so we can have a panel discussion.
Hello.
So,
could I ask questions from here now?
Yeah, please.
Thank you to all of you for your excellent presentations. So this question for Dr. Subashini, I think excellent videos. Thanks for sharing them. I'm Sudeep Tabata from UK. So a very interesting talk. For trabeculectomies, I saw your kind of triangular flap. Do you make any modifications to your usual trabeculectomy while doing these refractory secondary glaucomas in compared to primary glaucoma? That's the first question. For example, you use releasable sutures, in the post-op period, and any different or additional manipulations in the first few weeks post-trabeculectomy. So, do you do anything different so that the blebs work better? Because these are likely to fail. So that's about the trabeculectomy. And I'll go on with the second question and take my seat. The ABC study, like you said, lower reductions for the Bevold and the AMED, slightly higher. But the failure rates for Bevold because of hypotony and loss of vision is significantly more. So do you have any preference of the glaucoma drainage device with regards to, for example, posterior uveitic glaucoma? Would you select one over the other for that reason?
Yeah, thank you. Thank you for those questions. Regarding the first question, so actually trabeculectomy would be indicated in the mild neovascular glaucomas. So because the risk of failure is very high, so modification in the technique of the trabeculectomy, so basically you can use releasable sutures, or if you have access to suture lysis, you try to aim on the tighter side. So you can use a higher concentration of mitomycin. So I generally use 0.2 milligram per ml for 2 minutes, but in these cases you can use up to 0.4 milligram per ml, even up to a maximum of 3 minutes. So with the help of releasable sutures, I think you can try to avoid hypotony. So err on the tighter side in these cases. and then try to, very important is the preoperative planning. So you need to give intravitreal injections of anti-VEGFs 1 or 2 weeks before the surgery. That would really help to improve the success of these glaucomas following these trabeculectomy surgery. Otherwise, in the majority of cases, and most of the glaucoma surgeons would straight away go in for a glaucoma drainage device. So the choice, I'm not too sure because of the cost. These AGVs tend to be costly here, and we have the indigenous make the RD implant, which is available in India. So we usually generally tend to use that, and very important that we use a ripcord suture in these cases. That's what I could see as the difference. I can ask my other glaucoma colleagues if they have a difference in management. Dr. Sharmila?
Yeah, I second all of that you mentioned. I think one additional thing which I would decide on the choice of GDD would be also based on the preoperative intraocular pressure. If I want a immediate, faster reduction in intraocular pressure, I would prefer to go for an AGV over a RD device.
Yep, thank you. I agree with all of your comments. Just a couple of extra comments, if I may. So for uveitis or secondary ones, I tend to use post-op 5FA injections in the clinics, and that helps quite a lot in prevention of the scarring of the bleb, and just long-term survival of the bleb is, I found them better. They all end up with the valve one way or the other, but if it works for longer, then we can delay the valve. And for the uveitis, again, because of ciliary body shutdown, I tend to use a valve device to prevent the risk of hypotony compared to a non-valve device, and that I found that quite useful. Thank you.
Thank you. Thank you for your comments and inputs. So what I would like to ask... yeah.
Subashini, hi.
Yes.
I'm Dr. Harsh, and Amit presented a silicone oil-induced glaucoma.
Yes, sir.
Just wanted to inform you that in 22 we me and Dr. Dinesh Talwar gave a new mechanism for silicone-induced glaucoma, in which there is a peripheral anterior 360-degree synechia because of leak of fluid over there. So that is not cited. That is the first time it has been described in the world. So you can just, if you ever present again, you can please cite that also. And we did a very, very peripheral iridotomy which could relieve it, because doing an iridotomy at the iris in the middle, the silicone oil doesn't move forward. So right in the periphery, the aqueous is trapped, and if you do a peripheral iridotomy, which is a very tough call, but if you can do it over there, in which you can initiate with only 2 millijoules, so that the iris goes a little back, and then you can hit with 6 millijoules, so that it suddenly opens up, and then the chamber is immediately formed. So it is in 22 in case report. It's in PubMed. The moment you just do Google, you'll get it. Thank you.
Sure, sir. Thanks, Dr. Harsh. Dr. Harsh is a senior glaucoma specialist, and we value your comments, sir. Any other questions from the floor?
I just wanted to bring up this point. Do you people routinely want to do a peripheral iridotomy in these eyes, given the situation that most of the patients who undergo VR surgeries, they kind of end up with a pupil block, though we don't see a significant number. But earlier, like what you mentioned, Amit, Antos inferior iridectomy was done. So, but now we are not routinely following that. So do you think that would help? And the second question is whether the type of silicone oil used, if you use 5,000 centistrokes, whether it would be lesser in causing such.
Actually, thank you, madam, for the question. Actually, rather than the centistrokes, which is 5,000, the indication of the silicone oil in that case. So if those, and the duration the silicone oil stays. So the goal should be, we should remove it as early as possible. Once the retina is attached, so we can plan for an early removal also. Usually by 2 months, most of the simple cases, the function of silicone oil is almost completed. So we can, in pre-existing glaucoma cases, we can even aim for an earlier removal. And 5,000 centistroke, as you told, the emulsification is less compared to the conventional 1,000 centistrokes, but that is used only in cases where the risk of retinal detachment is very poor prognostic cases, where you want to leave the silicone oil for lifetime, so you don't need to remove it. So because removal of a 5,000 is very difficult, so this is between the choice of the silicone oil. Only thing is the time of removal is very important. So whenever we are seeing, because most of these studies, I think, says that only long duration, because during COVID time we have seen many cases, silicone oil induced glaucoma patients who had not turned up for more than a year. They had come directly after 1 year or so. So duration of silicone oil is the most important thing for emulsification.
Thank you. Yeah, we have also observed a lot of around 6,000 patients we have taken, and we found around 60 eyes who developed pupillary glaucoma following a vitreoretinal procedure. This is in the breast, actually, in seminars of ophthalmology. So we came across a few of the risk factors, like what I mentioned, doing multiple vitreoretinal procedures, that is having a combined procedure with a cataract, multiple vitreoretinal procedures, that is a risk. Secondly, use of 1,000 centistrokes, possibly because most of the patients where we saw were all of them who had 1,000 centistrokes, and there were very few with 5,000 centistrokes. And inflammation, post-operative inflammation. I think what is more important is you have to treat them intensively with steroids, because any procedure, whether it is like trabeculectomy also, a certain percentage, 50 to 60% works well if you give an intense steroid course, because you don't want the bleb to fibrose. So we are not ruling out a possibility of not doing a trabeculectomy. I know many of us here are not really very familiar with doing a tubes. It does involve a lot of skill in learning the procedure. So still trabeculectomy can still be tried. Of course, in good hands or people who are very well versed with tubes, I think tubes are the primary surgery in these eyes.
Yes, thank you, Sharmila. Any other questions? So we can just ask other questions to the panel. So this is one common question asked. IV mannitol in post-vitrectomized eyes, so eyes which had undergone pars plana vitrectomy and the pressures are high. So in these eyes, will IV mannitol work?
I think yes and no also, because number one is, I think generally we take out most of the vitreous volume. So what happens with intravenous mannitol is it kind of like shrinks the vitreous volume. So already in a vitrectomized eye, there is a lesser amount of vitreous that is present, and so I'm not sure if it is really additional benefit. However, given the very high intraocular pressure, it does have a central mechanism also. So irrespective of just reducing the vitreous volume, it has a central mechanism which has been published also by our colleagues from Coimbatore. So that says that it does help in reducing the intraocular pressure.
So always try first with IV mannitol when the pressures are high. Then another question. The retinal surgeons use left and right anti-VEGF injections. So just want to know which are the cases which are high likely to develop glaucoma. Dr. Shreyas.
Usually what we see is like the CRVO cases are these days with anti-VEGF therapy, actually what I had already told in my talk also, usually these cases NVG used to develop within 3 months in ischemic CRVOs. Now actually we cannot predict when it actually develops.
Even after anti-VEGF
Even
injection?
after anti-VEGFs. So it can actually develop later also. So these cases are prone for NVGs.
Okay, thank you, audience. So this, in fact, is, as I told before, it's a different instruction course where we involve the retinal surgeons. So it's very important the glaucoma specialists have a sound relationship with the retinal people, just like me with my retina colleagues. So, because there are conditions which could be actually posterior segment disorders. They could be red herrings here. So, it's very important to have a team management in the best interests of the patient. Thank you.
Thank you.